First up, though, let's talk to someone who used to be in charge of the NHS. Stephen Dorrell is a former Conservative Health Secretary. He's also a former chair of the NHS Confederation. That's the body that represents the NHS bodies. But he's now a Liberal Democrat politician. Stephen Dorrell, thank you so much for joining us.
Good morning, Julia.
Thanks so much. Was there anything in this fairly sizable report from Lord Darzi that you didn't already know?
I think the short answer to that is no. These are very familiar themes. The waiting times for NHS planned care, NHS urgent care, access to GP services. These are all, this is a very familiar story. It was, in truth, getting worse before the pandemic. It, of course, got significantly worse.
Waiting lists were already sky high before the pandemic, weren't they?
Correct. And I think it's important to say that. And that's why I actually agree with Keir Starmer that there needs to be reform. I doubt, frankly, whether it's possible simply to wait for reform before providing more money. Because I think that, in truth, the two need to go together.
Even though we've got a record funding, £165 billion. I mean, that's not far off where a lot of other successful healthcare systems have got their funding per head of the population. It's more than Spain have, and you've got a better chance of staying alive in Spain.
One of the things that I think Darzi doesn't cover, and I do think it's quite a serious weakness in this report, actually, is the funding of social care. Part of the reason why NHS productivity is falling is that people arrive in hospital and indeed stay in hospital longer than they need to because the social care system doesn't provide the support outside hospital that would actually be better for those individuals, as well as meaning that people could pass through the NHS more quickly. Yeah. And indeed, many of them never appear in the NHS at all.
Yeah, well, that's the thing. An awful lot of the people who need the healthcare the most urgently never even go to their GP, let alone get any further down the road. We in terms of what's been identified as issues, austerity 2010 onwards, definitely an issue. Real terms increases, but much smaller than they had been before. We've got the Lansley reforms. They've been much criticised, but also, obviously, COVID. But as you say, I mean, lots of problems happened before COVID. Waiting lists were already going far, far up. And also, you know, one thing that's not being mentioned, of course, is the doctor strikes. But again, that is although a massive hit, it's far less than anything else. But I mean, even in terms of COVID, we are unique in the Western world as a country whose healthcare just turned into a national COVID service for about a year instead of treating anyone else pretty much en masse, but also has taken so long to recover. Every other healthcare service in the world is back to normal now. Why isn't ours?
Well, I think actually those things are all related. The fact that the management system wasn't working as well as it needed to after the Lansley chaos, the fact that the system was relatively underfunded in the period before COVID, the fact, importantly, drawn out by Lord Darzi, that capital investment in new hospitals and, very importantly, in new digital infrastructure, new kit, all of that fell behind in the years before COVID, meant that the system wasn't resilient at the time of COVID, and the COVID effect on the health service was actually more serious than it would have been if the system had been better managed and better sustained, more sustainable at the time COVID hit.
Yeah. Does a lot of this come down to poor management? There's a lot of people to say, we had some callers, people saying, look, you know, loads of different health secretaries over the years, even under the Tory years, and it's the same, you know, the same party in power, but different health secretaries, all these different reforms, people doing different things. There's been no coherent vision. Now, I pointed out, I don't like the word vision when it comes to this. This is a really simple job. This is keeping people alive. I mean, it's really that simple. You don't need to have a vision. It's not, you know, got SpaceX doing the first ever commercial spacewalk. I think then you need a vision to do something like that. This is kind of what every other functioning country does, giving healthcare at a timely time to people who need it. It seems to me to be something that doesn't involve a vision. What is the issue? Is it the people who are actually in charge of the NHS overall? Is it individual managers? We know there's a culture of cover-up. We know there's a massive bureaucracy. There's lots of failings there. But where is the problem? Do we need to just sack everyone involved in management today?
Short answer and long answer, actually, no. That's not the answer. Darzi is very clear, actually, that fundamental change of the management structure is one thing that should be ruled out, and I'm pleased to say has been ruled out by the government. We've done that repeatedly in the past. We've imagined that we can create fundamental change by changing the management structure. It doesn't work. We know it doesn't work. What we do have to do is the hard yards. The thing that you said that I strongly agree with is that it isn't difficult to define what we're trying to do. What's difficult is actually doing it. You can make the speech, you can define the vision, if you will, but actually what you've got to do is the day-by-day delivery of the ambition that you articulate. And that's what the last government, frankly, was not good at.
Yeah, but again, we're told constantly by government ministers, we're not in charge of the day-to-day running of the NHS. We don't get to decide whether or not Jane is on shift and Derek isn't, and which operations you do and which ones you don't. That's down to the consultants. That's down to the hospital managers. They're not in charge of that stuff. I mean, when you've got more consultants and they're carrying out fewer surgeries, I mean, is that the fault of the health secretary?
Well, of course not. It's at one level, it's of course true that if you're health secretary, you're not making day-by-day decisions in individual GP surgeries or dentist surgeries or wherever else the NHS is delivering care. What you are responsible for as health secretary is the structure, the system by which people make those decisions, and importantly, the distribution of funds within the system. And I make the point again, if we fund hospitals but we don't fund social care, we shouldn't be surprised if people end up in hospital when actually they'd be better cared for in social care.
Yeah. And indeed, we know the huge extra cost of someone being in a bed in hospital, whether they didn't need to go in the first place, if they'd had the adequate social care, or they're stuck in because there's nowhere for them to go when they go home because there's enough places in a care home and there's no one to care for them at home. It's a complete false economy because it's a fraction of the cost to have someone cared for by a carer at home than it is to have them in a hospital bed. So, but my God, I've been a political journalist for years. But Stephen, I've been writing about this for about 20 years. You've known about this for years and years. Why hasn't anything changed? Why is everyone involved so incompetent and incapable of saying everyone knows what the problems are and nothing changes?
It's not quite true, so in fairness, to say nothing changes. It changes unbelievably slowly. And the opportunity...
Well, then it's not change.
Well, it is changing, but changing too slowly.
Are there still roughly 15% of beds being occupied by elderly people who don't need to be in hospital and could be in care? Yes. Well, we knew that 20 years ago, so nothing's changed.
And it's even more than that, actually. I think most of the measures would quote a figure of higher than 15%.
Yeah, I was being conservative.
You were indeed. What I think we need to recognise, something you were saying earlier, actually, that this isn't about a grand vision. Numerous politicians have made the speeches, including me. This is about hard yards. This is about doing the detail. And importantly, the shift that Wes Streeting talks about, which I completely agree with, the shift out of hospital, into community, into prevention, into social care, that's something every politician has talked about, fundamentally necessary, and we need to create a system that actually delivers that day by day, week by week. If we do that, we should be delivering not merely better value, we'll be delivering better care for people who rely on the system.
Do we need to just dump the whole idea of this monolithic structure employing, 1.5 million people, the NHS, on the basis that no one has copied it? If it was such a great idea, they would have copied it. Other countries don't have that system. They've got this sort of social insurance system where the government basically underpins, makes sure that those on the lowest incomes are always covered by, by the state, but everyone else pays in and pays their whack. Do we not need to just abandon the system we've got and move to a system that we know works everywhere else?
Well, I don't agree with that. It's a specific issue. It's a specific issue Lord Darzi looked at. He doesn't agree with it either. Partly because other systems elsewhere in the world are actually more expensive than ours are. Ours is. It's also wrong, incidentally, to talk about the NHS as a single monolith. It isn't a single monolith. It's a group of hospitals, group of GP surgeries. People forget about the pharmacies. It's social care as well. It's a whole range of different service delivery units. What we don't have is an efficient way of coordinating them to deliver joined-up care.
But the whole point is it is a monolith in the sense that, you know, I've only got one GP, I've got one local hospital, you know, I can get an appointment. I can't go to an alternative service unless I've got money to pay for private healthcare. And so people don't have access. And the idea, I can go to a hospital in Glasgow. Well, most people can't do that. I mean, people don't have choice. When you don't have choice, you don't get that competition. You know what? Even if it was costing more, I mean, again, and some of these systems that work much better than us don't cost more per head of the population, actually, that actually, you know, we spend a huge amount on bureaucracy, despite the fact that we supposedly don't have that competition. People probably wouldn't mind paying a bit more if he knew that it was going to keep them alive longer.
What I think people would welcome is that instead of imagining that this is a single monolith, it isn't a single monolith. It's a group of, of silos. Part of the problem is that it's a group of silos that need to be more joined up. And one of the ways we can do that is by investing, as Wes Streeting, I think, quite rightly talks about, using digital technology to give information to individual citizens so they can make decisions for themselves.
That's all very well, but an awful lot of people aren't able to do that. What we mean...
That's not true. No, you're...
I'm not. I've worked in a GP surgery. I can absolutely tell you that there are an awful lot of people who have no idea how to navigate the system. I'm as sharp-elbowed middle class as you can possibly be, and I find it hard to navigate the system.
Yeah, and me too.
Well, then what does that tell you?
It isn't just about navigating the system. It's about choices you make about your own life, your diet, your lifestyle, the way you lead your life. That's information that can be provided to people much more efficiently.
They know it already. They do. Well, Stephen Dorrell, we'll have to leave it there. It's so interesting to talk to you, and always appreciate you coming on the show. He's a former Conservative Health Secretary, but he is now a Liberal Democrat. I must stress that.